And so we start with leveling the battlefield. You all agree that for limited, isolated, resectable colorectal liver metastasis, the standard of care should be cytoreductive surgery with perioperative systemic treatment. The whole panel agrees with that? Yeah. Okay. So, and these are the current guidelines. If you pick up the major guidelines, I think NCCN is the only one that has removed the recommendation for cytoreductive surgery, that is after PRODIGE 7, which is a little bit unfortunate. We have made our Indian guidelines, and of course cytoreductive, because it just involved surgeons, cytoreductive surgery was of course considered a treatment option. For HIPEC, we were very strict with our recommendations, and we'll come to that later. So the first case, it's a young male who presented with pain in the left lower abdomen. He had no other symptoms, and the ultrasound showed a growth in the sigmoid colon. This growth on colonoscopy was at 25 centimeters, 8 centimeters in length, no obstructive symptoms, and it was a poorly differentiated adenocarcinoma. This is the CT scan, and there was moderate ascites. Peritoneal disease was already seen on the CT. The tumor markers not raised. It was a KRAS mutated tumor. The patient was quite fit. He had no comorbidities. So will you consider this limited disease? You just have this information. Is this limited peritoneal disease or is it extensive disease?
No, I would not consider this as limited disease. I can see ascites, you can see visible peritoneal disease at least on the seros also sometimes.
Yes,
so definitely not limited and nothing, not for upfront.
So once you are seeing ascites and you are seeing definite evidence of peritoneal disease away from the primary in the upper abdomen, in most cases it is extensive disease. You would not call this localized disease. So what would be your next treatment plan? Would you order some additional investigations or directly start the patient on treatment?
In this particular case, I think the extensive disease is very well appreciated in the scan. But if there is a doubt, there is minimal ascites or there's just stranding which is seen, then definitely a diagnostic laparoscopy would help. But in this particular patient, I think it's very, the imaging is showing a lot of burden of disease.
What about NGS? What about ctDNA, the medical oncologists? Let's assume we are not short of funds.
Yeah. So an MSI would be for sure. I think it was
it's MSS.
MSS, yeah.
MSS.
And then that information that you've given is good enough for us to start chemotherapy. Whether NACT intent or not, I don't know. But we will definitely start chemo and then take it from there. ctDNA in stage 4 cancers you can do, but I think it's far from essential.
Yeah, at the moment it is not the
plus
standard
minus.
of care. Yeah. Dr. Diva, would you order any additional imaging?
I think if the CT is done in a good, like multi-slice, good slice CT, then it is sufficient. And since this is adeno, it's not a signet as far as...
no, it's poorly differentiated.
Poorly differentiated. So CT is the second thing. If there are any dilemmas of peritoneal spread, particularly if we are talking in the context of the supramesocolic omentum or the lesser omentum or specifically any other dilemmas on, then I think better to get one either FDG PET or good MR peritoneum for truly to know the exact locations of the disease, because after NACT we don't know, sometimes we might miss those plan of the surgery. So if this, so it depends on the...
I agree with you. For me, a more accurate disease mapping in this patient, if logistics permit, either in the form of a staging lab or in the form of a MRI peritoneum, it would help me define the intent, whether I'm going to ever consider this patient for surgery or not. It would help. And what about the treatment? I think you all already said we would start with chemotherapy. I don't think anybody is going to assess this patient for the possibility of upfront surgery. So this patient was started on FOLFIRINOX, and 4 cycles were given without any difficulty or major side effects. Any quick comment from the medical oncologist on the choice of regimen?
I think you're looking at significant cytoreduction before thinking of going in. And if the patient is fit, this is a fair option. You could have added BEV as well.
That's the whole point.
Yeah.
Is there any reason why BEV was not given? Patient
So,
ascites.
this patient came to me after the FOLFIRINOX.
Okay.
So,
So
but
probably
fair.
could have given BEV also.
Yeah.
Maybe FOLFOX plus BEV. FOLFIRINOX is also not wrong. That is okay.
Yeah, I agree. So this is the CT after 4 cycles of BEV, and I'm not going to ask the radiologist to comment on the actual findings. The disease more or less is the same. You can see the ascites is still there. You can see the peritoneal thickening. There is significant amount of upper abdominal disease. There are visible omental metastases, and there is of course a lot of disease in the primary and in the pelvis also. So the radiologist said, that there is an increase in size of the peritoneal lesions and its progressive disease. And we do not really have a raised tumor marker level, because sometimes when the radiological findings are discordant, the tumor markers can point towards a response or no response. And the patient has not had any increase in his symptoms. His performance status still remains good. So what would you call this, and how would you proceed from here? First, the radiologist, what are the fallacies in evaluating the response in these patients?
So sometimes if we see on the basis of the RESIST criteria, the actual cellular part of the tumor get reduced, and it leads to more of the mucin production. So, and that leads to increase in the sizable peritoneal deposits. That's the one thing which we see in couple of patients. And in that context, that is why I have emphasized on MRI, where it really differentiates between the cellular and the acellular mucin. So that's the one context. If it was secreting priorly, and then if the markers have gone down, so we really have to think twice before telling that it is really a progression. So that's the major one of the criteria.
So, from the other panelists, I agree with you. Assessment of radiological response, even if you use the RESIST criteria, where you most people don't apply it. They will not look at that 30% bracket. Just a mild increase in size of the lesions would be termed as progression. Some increase in the quantity of ascites would be termed as progression. So what is the impression of the rest of the panel? Which way is this patient going?
What is the status of the chest?
The chest is still clear.
So it was baseline clear, now also clear, and this is only in the below the diaphragm.
Yeah, it is only peritoneal disease as per the imaging that we have.
Okay, so as we had already given FOLFIRINOX, which is a reasonably aggressive therapy, and even though probably BEV was not given, it has a lukewarm response, and the peritoneal disease is still there. So if there is no chest disease, patient is fit, then of course the surgeon has to again take a call whether the surgeon can go in and do CRS.
So even with this sort of advanced disease, you will seek a surgical opinion?
Because it's not responding to the FOLFIRINOX. If it's not responding to FOLFIRINOX, we do not have much armamentarium left with me, because this KRAS mutated. I can't give cetuximab and BEV. So BEV probably something that can add on. But if FOLFIRINOX is not buzzing, then probably we are looking at a chemo-resistant disease. So if it is still localized to the abdomen, below diaphragm, chest is clean, patient is fit, then that should be discussed.
Okay.
So we would discuss with medical oncology. If FOLFIRINOX is already given, you don't have much options left. But if you can try with FOLFIRI-BEV.
So one thing is, should we take a call on this? I mean, this is more a stable-ish picture than true progression. I mean, I can at least see 2 people nod.
Yeah.
So we don't have to take a call right now, is what I feel. Give more chemo, give BEV, wait for 2 months since the patient is not having too many new symptoms, right? And the one thing is that this patient is not one of your better candidates, because she's not
The point
responded.
is, if he's not responding to 4 cycles of FOLFIRINOX, then whether you respond to 6 cycles of FOLFIRINOX, that is a very difficult decision. It all depends upon the fitness and what is the intent from the patient side.
So we are dealing with a 35-year-old fit patient who's not had a great response with 4 cycles of FOLFIRINOX and has been recommended switching over to second-line chemo. So I think before you switch on to second-line chemo, one very accurate assessment of resectability is
Fair.
essential. Yeah.
Probably a laparoscopy at this point.
Yeah. So, based on imaging, at least my assessment was that it is resectable disease, and with a fair amount of certainty, you can say you will go in and resect all the disease. But we went ahead and did a staging laparoscopy. Just one word on PIPAC. Anybody here would consider PIPAC? Anyone at all would think
So what
that
are your
PIPAC?
thoughts on PIPAC, and then we'll let you know. Yeah.
To see once how that PIPAC is done,
our
how exactly
understanding.
the inhaled
So our
chemo is
understanding
given.
is that it's essentially for refractory ascites, right? I mean, and anyone can correct me.
For me, this is not a patient who will respond to PIPAC.
Okay, great.
I
That's-
think the patients
yeah.
with such large peritoneal nodules,
Yeah.
when the patient has massive ascites, miliary disease, and colorectal is again not a disease that, in my opinion or experience, such a disease would not respond to
and
PIPAC.
Your thoughts on the whole downstaging with PIPAC, because this is a term I hear often. I mean, does PIPAC actually downstage?
For me, talking about gastric and talking about mesothelioma, where it may have a major role, I would really want to see some randomized data, because 2 randomized trials on PIPAC were stopped. So we use it when we run out of options, but am I really convinced it works? No. So we did the staging laparoscopy, and the laparoscopic PCI was 17. The small bowel was completely free. There was no sign of unresectability, and we have these laparoscopy images. The disease looks quite angry. It looks quite bad. There's disease
Can I have
in
one question, just to my
Yeah.
understanding? This scoring of assessment of PCI,
Yeah.
is it uniformed and standardized? And as a medical oncologist, can I be assured, or the patient can be assured, that irrespective of whether it goes to a high volume center or a small volume center, at least the assessment, that means PCI scoring, will be standardized? Are you all convinced that it is standardized everywhere? That means one person does a PCI scoring, other person does a PCI scoring, it should match. Does that happen?
So in literature, the way to score it is very well defined, but recently there was... Yeah. So in real practice, we were just running a study in which these images were sent to top cytoreductive surgeons across the world. In that also, consensus was not met in so many places.
See,
don't
Kazi,
go
do
by
you
the
want to
number.
say anything?
Yeah, we,
Do
don't,
you-
we don't go by the number. We are looking
Exactly.
at
Exactly.
signs of unresectability.
by the number.
It's not just the number.
Because the results of the trial say less than
I
10,
know.
more
Yes,
than 10
yes.
to 19, more than 20.
So more important, that would be like signs of unresectability, amount of small bowel involvement, is root of mesentery involved. Is a
Let's
porta
say you
involved?
use a cutoff of 17 and the PCI is 18. The disease is resectable. Will you abort surgery? No. That is
Yeah,
the...
and I think what you said about the actual sites of involvement, small bowel would be much more important than something else, even it is 15, right?
Yeah.
Yeah.
So in this particular patient, there was disease over the entire parietal peritoneum. The disease in the primary was quite bad. It was massive and filling up the whole pelvis. There's greater and lesser omental disease, but the small bowel is completely free. And surgeons, any quick comment on these images? Do you ever, the tumor looks angry, there's hemorrhagic ascites. Will it change your treatment plan in this patient?
So although they look angry, they are still of the better types rather than plaque forming, rather than real confluent, rather than those which are constricting
If
the
this
mesentery.
was a
So these are still
signet-right
better.
morphology.
These still look better than many of the other ones.
Okay. So we went ahead with surgery, and we were able to get a complete cytoreduction. The PCI increased to 24, which we expect from laparoscopy to open surgery, because the tactile feedback is not there in laparoscopy. We did perform the HIPEC for this patient, and we'll come to that later. We did a transverse rectal anastomosis and a diverting ileostomy. And this is what we were just discussing, that we don't treat the PCI as an absolute number. If the disease is completely resectable, if you use a cutoff of 20, some studies use a cutoff of 20, some say it's 17, others say it's 16. But if you have completely resectable disease, I don't think it should be a reason to contraindicate surgery. What is the practice in TMH?
We don't have a number cutoff. Oh, it's about resectability based on CT and then intraoperative, but not a number cutoff.
Yeah. So I
The
think the
problem is
slides
that now
are.
most of the trials and the guidelines will be based on a number.
See, we
And
don't
then in
have.
the,
Sorry to
then
interrupt.
when you, in a real world practice, when you see that probably the number is not the only thing that you will look, then it becomes slight contradiction that on one side all the trials say, and the guidelines of the flowchart says that you look at the number and based on the number take a call. And the other side we are saying that don't look at the number alone, and it is the individual surgeon's perspective based upon his experience, based upon his entire lookout, you take a call. So that slightly becomes a bit contradictory. That's so how to go about that, because from medical oncologist point of view, when the patient comes and asks that, oh, this has been suggested, what should we do? Then there is no objective answer.
So we actually don't have any guidelines on colorectal peritoneal metastases. We have the Chicago consensus from the US that was recently updated, and we have made our own Indian guidelines of the two Indian societies. We did not have medical oncologists at this point because it was the first time. But our recommendations are quite clear that we will not use a strict PCI cutoff, but we will look at all parameters. So the surgeons
It
can
still gives a fair assessment of disease burden, but don't look at single unit increase. Maybe in chunks of 5 or 10, and she's leading another effort of maybe standardizing it better. But we don't have a better way of assessing rather than. But it's just the best way to communicate at this moment of time.
So there is also some data coming in, like this study where they got a median overall survival of 20 months in patients with a PCI of 20. I think we have to be guarded when we offer surgery to patients with such high PCI. We have to inform them that the survival is not going to be 5 years. We are not going to cure them. They are going to recur early, and the average survival is 2 to 3 years. If that is acceptable to the patient, you are not bringing down the quality of life, you are not causing morbidity, it's okay to go ahead with surgery. And this is one flowchart we came up with where we do not consider the PCI as an absolute number, but we look at the disease distribution. So now everybody has to pick one. Okay. What will you do about the HIPEC? Only in a clinical trial, not even in a clinical trial? Or there are selected patients who should get HIPEC?
You have to pick 2.
Okay, you get to pick 2.
Yeah,
Surgeons get to pick 2.
Yeah. So ideally, it should be within a clinical trial. However, the practice is that we are offering to all patients.
Same here.
Same here, Dr. Amol.
It should be one. It should be
should
part
be in
of
a
the clinical
trial.
trial. Because point 2, my main question is that if the disease is not responding to systemic chemotherapy, how will it respond to the local intraperitoneal or heated chemotherapy? That's something, it's a bit of jiffy. So I will stick to 1.
I think you're not going to have large trials in this. The available trial says it's iffy. So if you're doing it in a clinical trial, use it in a trial. If at all you want to use it in that 11 to 15 artificial bracket. Otherwise, I think a good CRS is far more important. That's, as a med onc, that's what I feel.
Yeah.
That the CRS, a good CRS is more important than HIPEC. That's what I
And
feel.
I think that we have to communicate the evidence to the patients because, especially in private practice, a lot of patients still come with that hope or hype about HIPEC, that it is going to be the game changer, the magic pill. So it's important to quote the evidence to them. So these are, this is a very interesting paper that was published very recently, and these are all national guidelines on colorectal cancer. 90% recommended CRS and 60% recommended HIPEC outside clinical trials. I think these are largely controlled by surgeons. And this is what we are planning on behalf of the SOGI, to have a trial in which we compare HIPEC versus no HIPEC. And we will do it as an observational study. This is still in a very preliminary stage, and Kazi is involved in designing this study, where we really need, even as PSM surgeons, we are tired of the criticism that we don't do evidence-based practice, and we really want to generate some evidence. So this patient also had a 5 by 5 centimeter CP angle node, which was discovered intraoperatively, and we did a transdiaphragmatic resection. There were nodes along the suprarenal IVC, which we found during surgery, and they were resected. And quick word on the involvement of these lymph nodes.
You can have them with heavy diaphragmatic disease, upper abdominal disease. So
Yeah.
if it's there, you remove, since we are already going ahead with a curative surgery. But it probably means that patient is also going to fail systemically.
Yeah, that's right. And it is because of the location of these nodes, they are probably secondary to peritoneal disease, but they do indicate a bad biology. So this was the histopathology report. It's now a moderately differentiated mucinous adenocarcinoma. Not really much response to chemotherapy. The nodes are positive. And fortunately, the post-op recovery was uneventful. What about the systemic treatment now?
Yeah, of course, you have to complete the FOLFIRINOX, and post-operatively, if there are no issues, we can after a month or all, you can add BEV and hope for the best. If you've not responded much, the only thing that probably will work is a good CRS, and if that is being done, then let's hope for the best. That's all.
Yeah.
Usually, once we have achieved a CC0, largely, and there's no visible disease, we would not give monoclonals. That's the usual thing. So yes, complete 6 months of chemo, yes, for what it's worth. In our head as medoncs, we all want 6 months. I don't know how much it will help, but we'll complete that.
Yeah.
Yeah, that's what I said.
Basically, it's a bad disease, so
Yeah,
you take an individual call.
But usually,
Because it was
that's,
not,
yeah.
not at all. See, it should not happen that the patient succumbs without receiving one of the useful targeted drug. That's all. One of the useful, not say the useful.
Okay. So, all right. So this patient did complete all 4 months of FOLFIRINOX, and OX had to be omitted in the last 3 doses. He gained weight, and as expected, he developed systemic metastases very soon after the last dose of systemic chemotherapy. So, and was the status. The patient remained alive on and off systemic treatment for 2 years from the date of surgery. The patient had lung metastasis, pleural effusion, liver, lymph node, and peritoneal metastasis when we saw him last. So, final comments. Did our surgery help this patient? We got away without morbidity, that is for sure. That's...
lived without obstruction.
He's asymptomatic for 24 months after surgery, except that he has a stoma. Because he developed systemic disease so fast, we were not able to reverse the stoma, which is okay, I would say. But apart from that, he has no symptoms.
I think that is one of the points at which this surgery really helps, where you have at least non-obstructive recurrence, because that is the main factor which then does not allow the patient to take systemic therapy, as well as decreases the quality of life significantly. I think if we are able to increase obstruction-free survival, that itself is a pretty plus point.
Yeah. So, any comments from the medical oncologist in
Yeah, of
retrospect?
course, the surgery did help him. There is no doubt about that. And CRS part definitely helps. Retrospectively speaking, probably something different could have been done. Was probably at the end of the entire treatment, ctDNA, if was feasible, it should have been done. And then, if it is positive, continue the wave, or
Yeah.
maybe oral cap should have been plus wave.
I
I'm
agree
of the
with you.
strong proponent that some of the other systemic therapy has to be continued in a stage 4 metastatic. Chemo-free interval is something
Yeah.
which is very difficult, and in that situation, ctDNA could have been helpful.
Yeah.
But that's of course a retrospective thing.
I think it is, what is the word being used here? Evidence-free zone. So maintenance treatment in such patients with so much of disease with a poor response to chemotherapy is where maintenance treatment could have helped this patient. And like Dr. Vivek said, surgery preserves the quality of life, and we so even with a high PCI, we are not going to cure them, but I think it even helps with the survival. You would not have got these 2 years with systemic treatment alone. So we'll move on to the next case, and this would be perhaps more interesting for the medical oncologist. It's a 41-year-old male with no comorbidities, diagnosed with a sigmoid colon tumor. He has a strong family history. The CA is 2.8. And there is a circumferential thickening of the descending sigmoid junction, and there are soft tissue densities in the hypogastrium. So the largest one is about 3 centimeters. If you don't see any images, then you get this report, primary tumor in these 2 hypodensities. Dr. Diva?
So he has some family history, as you say.
Strong family history.
Okay. So are we dealing with some syndromic situation? That's the one differential which I can think of. Familial adenomatosis, polyposis coli, or are we? And of course, we need to look for, are there any other soft tissue densities are mentioned in the hypogastrium, but not mentioned as they are within the bowel or what?
Yeah.
So we have to look for the entire colon thoroughly. What's happening?
Or maybe these are abdominal
or
wall
these are the
tumors.
FAP
Desmoid, FAP.
with a fibromatosis coli or something.
But still,
that's
if you
what-
don't, or mental
Or-
disease,
So then
Momentum doesn't
this
fit in.
patient just had a robotic anterior resection. This is not when we saw the patient, and MSI was not done. Those 2 lesions were ignored.
That too in Virat's meeting.
No. This is not me.
Virat's city.
So this was, it is a PT3 tumor. LVI and PNI are seen, 2 IMA nodes are positive, and there are extramural tumor deposits, so it's PN1C. So I think MSI testing, everybody agrees to. These 2 lesions should have been investigated. They should have been, at least the surgeon should have tried to look for them during surgery, even if the plan was to operate. And what if this was MSI high? Before the surgery, then what should be done for this patient?
G1-IO is a pretty good data for that.
Okay. What if the MSI comes after the surgery? If it's MSI high, then no systemic chemo, only IO?
In 2022, we would have treated this as a low risk stage 3 and given 3 months of chemo. In 2025, we would give chemo plus immuno.
Okay. Fine. So again, no MSI testing was done, and the patient was given 4 cycles of Kpox.
That is very amazing. No? The robotic surgery was done, but the MSI testing was not done.
I'm not the culprit. So I think we all agree that MSI should have been done at some point, and we should have evaluated those 2 lesions. The patient is 41-year-old, is a 41-year-old with no financial strains. So then he develops lower abdominal pain and discomfort. CT thorax abdomen pelvis is normal. CA is higher now. It is 2.8. It was 2.87. It is nearly 6 now. And the USG abdomen and pelvis is showing mild increase in size of the two hypogastric lesions. Again, the patient is just treated by a physician and there is an increase in the abdominal discomfort. The CA is jumped to 13.1. In April 24, the patient developed symptoms of intestinal obstruction. There is low abdominal pain and back pain, and PET CT is done now. And there is widespread metastatic disease. There are pleural nodules, anastomotic recurrence, retroperitoneal lymph node causing hydroureteronephrosis on the left side, and omental, parietal peritoneal and mesenteric deposits. There is a lytic lesion in the left lib which is marked as metastatic. Dr. Diva, quickly, any comment? Nothing? Anything else? I think FDG PET in this situation is good enough. So what would you do for this patient? Surgeons and medical oncologists, what for the obstruction and what?
In the imaging part, not mentioned about the disease is widespread, but not mentioned about there is really the signs of obstruction or not. I mean, that is very important.
So I think he actually developed obstruction a little time after the PET. When the PET was done, he did not have obstruction, and then in a couple of weeks he developed obstruction.
Okay. Because that's the major information which
Yeah.
the clinician wants in a widespread metastatic.
Yeah.
If the
So-
obstruction is at the anastomotic side, then stent first.
Stent for the ureter, for the bowel, and now we would still test the MSI at this point. Okay, so it was tested and then we have it is MSI high, and what would be the choice of immunotherapy for this patient?
Yeah, now once that the obstruction part is taken care of and patient is fit, of course the immunotherapy should be given. The only discussion is single agent or double agent.
Yeah.
I am of the favorable of a single agent as of now. Viraj will go for double agent. He likes the EP for whatever reason, but I will go for a single agent and see how the things work.
The other thing is, only as SNE is saying an MLH1, we need to be a little sure of that. That does not necessarily mean
Correct.
it's MSI high. So we need to be sure of that. And if feasibility is not an issue, give them dual immuno. I think that's fair.
Okay. So this is what was done. The patient was started on Atezo in June 2020.
This is another amazing thing from this case. From where the Atezo has come? Huh?
If you have one guess, you have only one guess for
This is
where
Bombay.
the Atezo has come
Okay.
from.
No, there is no Bombay. This is
Dr.
Mumbai.
Amol.
And Mumbai, we don't do Atezo here.
No, you're supposed to be nice and not ask such questions. It's not our fault.
So I've still not seen the patient. There was a Atezo was started, and in October 2023 there was a complete radiological response at all metastatic sites except the abdominal wall lesion on the left side. It was now confluent with the anastomotic recurrence, and there were some new lesions along the pelvic small bowel loops. So how do you assess this? You know, this is immuno. There are new lesions. We don't know what that abdominal wall lesion is. And the anastomotic recurrence is there. So it is anything other than progressive disease. Can it be? Is it?
We've not yet done a biopsy of that troublesome thingy, right?
No.
It's troubling us for 2.5 years. So maybe we should put a needle in there. That's one. And if it's the patient has not had any new symptoms, and this is an initial assessment, let's say after 3 months or something, we should not call it progression. I mean, give it whatever other terminology you want, let's not call it progression, and recheck after 2 months or so. But that thing, whatever it is, would be good to put a needle in. Yeah.
The IO is given, we suddenly become very optimistic.
Yeah.
Okay. So, what would you do next? This is the CT. Some new lesions are there. Most of the lesions have responded. You will continue the TISO? Anything?
So if you are saying that it is partial response, whatever IO that was started should be continued. If in a multidisciplinary meeting it was convinced that it is a progressive disease, then the only option left is to go for double IO and see whether that helps. Because once it's an MSI high, not responding to single IO, some patients may respond to a double IO, but that's all. And of course, chemotherapy needs to be given.
In the studies which they were progression on IO, they usually continued IO with chemo. So for whatever it's worth, that would probably be the better option.
So you would add chemo to the IO at this point because of
do something different, assuming the MDT says it is clear-cut progression. If the MDT says no, it's iffy, we can continue the same thing and do an early response and see.
But you would not change the IO.
It's been
if
started.
If you are adding chemo, you
it's
will
been
still
started and it's not my fault. So, but if I'm changing, if I'm adding chemo, I would maybe go to something more standard.
Wouldn't you add CTLA instead of chemo?
What are you saying, sorry?
Are you saying
Shouldn't you add? I agree, you should add. But adding CTLA makes more sense than chemo.
Yeah,
I don't think.
I will not disagree here.
Yeah.
You can add CTLA, anti-CTLA, that means EP. That means
But
dual IO.
what was done in the studies was they added chemo in 80% of people. For
What you're saying is also correct. If one IO doesn't work, whether the two will work, even though the mechanism is different, chances are less. Cytotoxic drugs still are a better choice if the IO is not, the disease is not buzzing to the IO.
Okay, surgeons don't want to operate, right? You are not going to touch this patient.
Good.
Okay.
There is a question for last discussion means initial evaluation post IO, and sometimes we think for the pseudo progression as radiologists are saying, but when there is a new lesions, so as similar case, so ideally there should not be previous lesion only should, but what my feeling is there was very small disease which were not seen initially, so any other thing from radiologist or should
I
we?
think that's what he said, that if we are not able to take that call, and it oftentimes happens, get the radiologist to comment. And oftentimes when we say new lesions, if they are only nodal lesions and not visceral disease, that's common. We now know that with immuno that happens, so we can consider that as pseudo progression. And then
So the tumor board decision are important, and it should include a radiologist also.
Because in such scenario, most important to compare the pre and post. I mean, it's in interim scan. So there are chances like the radiologist have missed those smaller lesions. That's the one thing. Or are they really new lesions, new sites, or it's just those lesions which has popped up in the metabolic activity since patient is on immuno.
So unfortunately, I'm not able to provide those images. It would be good to have them. But then this is the imaging, and there is increase in size of the existing lesions consistently, and the CA is also increasing. So this patient was then started on FOLFIRI-Bev. With this, do you agree with this treatment plan?
They should have done a rebiopsy and just to have a fresh ingest on that to see whether something new is happening, because he's not buzzing, he's not responding, and if he's a younger patient, money is not an issue, you should have a rebiopsy. You never know that maybe something new, fancy things for Viraj may come up on that.
And
right?
the SNV at the beginning, that was a major thing. Is it really MSI high?
Yeah, it is
I
a
think
germline.
it was
He has a
confirmed.
germline.
It
Okay.
was confirmed.
He's
It
lynched.
was,
Then this is just bad disease which is not responding.
So again, the important point of discussion. So again, this patient didn't take CTLA, and I would still bet on CTLA only. The thing is, peritoneal only disease with MSI high. There was a Scandinavian report which said that they didn't do very well with IOs, even in MSI high status. and there was a case made for resecting the peritoneal disease and then continuing IO. And I think so that is the main thing where we will need to do MDT, that surgeons will have to, now you cannot because now it's a cocoon abdomen, but should have or could have taken out the peritoneal disease.
If it's responding to all other sites, disease only to the peritoneum, yes, that can be done.
So this is peritoneal only disease.
It is all
Mainly
the other
peritoneal
sites of disease have gone, and it is confined to the peritoneum. Of course, no surgical referral is made, and the same IO was continued. Then it was changed to Folfiri-Bev. Then on Folfiri-Bev, the patient had progression. That is when the patient was sent for a surgical opinion. And this is that lesion in the abdominal wall. I think I have a good MRI here. Yeah, so finally we have some images for the radiologist. I hope this plays, yeah. And it's sort of a large lesion which is confluent. It's not a very nice looking one. Yeah. It's not a simple resection by any means. You want to comment, Dr. Diva?
No, I was just thinking it's very unusual to have, the sites where there is continuous progression and because it's truly into the rectus abdominis.
It's not an easy resection. I think this patient will have to have a lot of abdominal wall resected. It's stuck to the bone. He might end up with a stoma, which we will have difficulty in reversing. And his only symptom is pain. So, any opinion from the surgeons on this? This is the only site now. This is
Resectable.
It is resectable with difficulty, not so easily resectable.
If you are convinced that other sites are in remission and this is the only site,
This is the
this is the
lesion.
parietal site, this mucinous.
Yes.
So T2 bright, probably
Mucinous.
mucinous.
It's MSI high.
T2 bright
MSI.
mucinous.
Is there any role of re-MSI testing in these patients?
I will get him a rebiopsy for
Just
sure.
rebiopsy and maybe
And then send for NGS and get everything you need.
It's a Lynch syndrome. We've proved it's Lynch.
Anyway, this was the lesion, and will you still consider dual agent for this patient? Or will you, do a relatively morbid surgery for this patient?
If it is MSI had, then dual agent IO before getting to the surgical part. Because that is the last thing, because it will be too morbid for a surgery for her. And if he responds well to dual IO, we can save that part maybe for later.
Yeah, you agree with that? Any?
I'm not seeing so much morbidity actually.
Because
There is nothing within the peritoneum.
No, it is going into the side wall. It is going into the pelvic side wall. A large part of the abdominal wall will go, the anastomotic
If
side.
there is side wall, then fine. But
If it
the
was-
image is seen
Yeah.
only bilateral recti.
It's just the
Uh,
If it was only recti, then it's
no,
relatively simple.
it's like if you see the skin, the skin will go. So there'll be a large difference. That is okay. That is okay. But if it's MSI high and there is still a chance of response to dual agent where cost is not a constraint,
No hurry in operating.
yes.
No hurry, no
What
hurry.
is the risk of? What risk does a different kind of immunotherapy entail? Is
If
there?
it responds, then the surgery also will become easier.
Now this is assuming that immunotherapy is not responding only to this site, while others are in remission, and if you are out of options, then
So we did start this patient on Ipi-Nivo, and it's been 3 months now. He's still on Ipi-Nivo, and we'll let you know next year what we do. So any final comments? Anything at all? Any comments on the 2 cases or colorectal peritoneal metastasis? Any quick comments?
No, so the only take-home message for this panel for everybody or the fellows in the audience is the MSI testing is compulsorily. Every colorectal or for that matter GI cancer should be tested for MSI, and it is easily available, not that very costly also, and it's a life-saving thing. Should be done.
Yeah. 2 other things. One, I think the Cairo 6 study is something really nice. Survivals were very good when you added chemo, and the CRS itself did very well. And two, I think none of us required any headgear, as Dr. Amol was worried about in the beginning. The helmet, sorry, in the beginning.
that Viraj has taken the reassurance. So that is why we'll have a post-panel discussion. Photo also.
Thank
We
you.
grow wise with age also. So thanks a lot to all the panelists for all the discussion.